How the topic of my talk came about was that Donata was with me at QPass and has me give a little bit of a similar talk in a couple of different settings when I've been asked, say, by a worker at QPass who's been doing amazing work with a client, say over 12 months, has a wealth of information about the client and perhaps has been getting stuck or, wanting some additional advice, finding the client difficult in some way. And the question is often, is there something going on? What is the diagnosis? And have I missed something? So it comes from this space of maybe there's something there that I haven't identified, that there's a name for it. What is it? And then am I not giving the appropriate treatment? So, and I get this kind of question a lot of the time from GPs, from counsellors, NGOs, psychologists. So, can you go back a little? I'll let you know. You're giving the punchline. So it's kind of a topic I've thought a lot about. So thank you for giving me a stand to talk about one of my favourite topics. So I want to look at what we're doing here right now to kind of give us a glimpse, to get us to think a little bit, step back a little bit, to look at the clinical encounter and to look at what we actually do when we interview a patient and try and arrive at a diagnosis. So I sort of was tossing up between, bombarding you with lots of technical jargon and psychiatric terms. I've decided against that approach and take a more general and conceptual approach. So right now, I am choosing certain words. I'm behaving in a particular way. I'm choosing certain slides, and I'm presenting all of this. All of this occurs in a particular context. So I'll give you a little bit about my background. I've chosen just to do this in pictures. So for example, I grew up in Vietnam and my schooling was a little bit like that. So I'm just going to try and learn to use this pointer. That's me, the attentive student. I trained at the University of Queensland and I've chosen a beautiful picture of the sandstone buildings there. I got my qualifications at the Royal Australian and New Zealand College of Psychiatrists. Note what sorts of assumptions, emotions, thoughts you have about these sorts of pictures and words and logos. Sorry. Am I going the right way? Is this towards the end of your talk, Amy? Sorry. Yeah. In a nice, safe suburb. One of my special areas of interest is with contextual behavioural psychology, and my favourite podcast is Philosophize This. So check it out sometime. Anyway, all of these things influence all the information, all the things I've learned over time and how I put them together and how I express them, what I call them, what words I use. And you're doing the same right now. You're listening to my talk. You're all hearing the same things. What each of you are choosing to write down, recall, tell someone about later, how you remember this information is all different based on your set of training experiences and the way you look at the world. So we're all interpreting machines. We're all interpreting right now. And culture is at play all the time. Culture is not just what sits with the patient. It's in every interaction. So I had a nice little cartoon. It might take you a little while for that to sink in. But basically, we're all fish swimming around and there's water around us all the time. A fish is, not aware it's swimming around in water. You all have that experience when you've travelled from overseas and come back. You get on the Qantas plane and you go, they're Aussies. What is it that makes it that? So that's the water that we swim in. And we can never remove that water. We can never be without that water, but that recognition that that's what we're swimming in is very important. And like what Rebecca's been saying and what Amy's been saying, when you're working with certain populations, that water's going to contain a lot of stuff and it may be a lot more murky and opaque. So sometimes cartoons are a good way of illustrating it. It's really stuck with me, that one. See, that's the stuff I'm talking about. Does that kind of make sense? So this may seem like a very non-medical approach to this topic, but I think it's really important to think about this stuff. I want to talk a bit about naming, labelling, categorising and diagnosing. They're different to the things that exist out there. What we call something is different from the thing that we've given a name to. So a 2-year-old child, you pick up an apple, you bring attention to it as a discrete thing. You might say the word, so the child pairs the apple with the word. And then eventually you can just say the word and the child will go to get the apple. So it goes backwards. And that's very useful. So when you're at a supermarket, you don't need to tear open the carton to know what's in it. Those little scribbles help you know what the content is. But the words, or the written word, or the sound of the word, or even labels, or diagrams, or pictures are just representations of something. They're not the thing in and of itself. And if we're talking about culture, for example, why is an apple a separate thing in and of itself? Well, our minds perceive it that way because it's useful. It sort of predicts something. If I pick it up, I can carry it around, I can eat it, and there's a thing inside that I need to spit out. We organise information when it's useful for us. For example, is it possible that some cultures may not see, just say let's go with a banana. If it's a culture that doesn't see a single banana, what if that's not thing that's how they divide it up, how they categorise it? What if it was always a bunch of bananas that they think of? So the water that we swim in determines for us how we divide up the world and how we divide up information. And the same with labelling. So the idea of a bouquet, that actually doesn't exist. It's just a concept and we refer to it and it's handy. But what the contents in that are, it can be many different things. It's just an idea. You ever walk down the library aisle or the bookshop aisle with, romance, thriller, science fiction. These are categories of things that don't actually exist. They're just our attempts to organise the world and understand the world. You can see how listening to philosophise this has influenced my talk today. Sorry about that slide. I'm not the best with PowerPoint. So I've just directly copied this, but it's close enough to what I'm trying to say. So and I think all of you know this, I'll quickly go through it. A symptom is an observable behaviour or state, and there's no implication that there's an underlying problem that necessarily exists or that there's a physical cause, like a cough or thirst. And the simplest level of analysing a presenting problem. A syndrome is the next level of analysis, and this term is applied to a constellation of symptoms that occur together or co-vary over time. That is, when one thing gets more prominent, the other thing tends to occur in a predictable way. And again, there's no implication of the underlying pathology. And a disorder is kind of like a syndrome. It sort of more means it's something that's sort of there but will pass over in time. and then the highest level of understanding is a disease, is a disorder where the underlying etiology is known. That is, there's a correlation between a set of symptoms and something anatomical, biological, neurochemical that you can measure that correlates with these sets of symptoms. So we kind of all know that at some level, but I want to look at that a little bit more. So as an example, thirst is at the symptom level. If you get this thirst, polyuria and weight loss, your alarm bells go up. It's like there's not someone who just needs to drink some water. There's something else going on, and it's useful to recognise that. And again, this cluster of symptoms that would get you to diagnose a diabetic ketoacidosis. And the idea is if you can recognise that, you can look for the things that will help you make a diagnosis of type 1 diabetes. You need to do some more tests, but you'll get to that diagnosis. And when you get to that diagnosis, it gives you a completely different set of actions to, someone who's just run a marathon or is thirsty or whatever the reason is. So with the history of psychiatry, we've gone through many revolutions many phases, and we don't have enough time to go into that. But the thinking's not been around for that long, but if we apply this model and we cluster symptoms that tend to occur together and we group them, that'll help us come to an etiology. I'm sorry to say, so far we've not had very much success with this approach, but that's the one we have, and that's the one we're stuck with at the moment. So for example, the symptom is feeling sad. Now there's an assumption that feeling sad is something that shouldn't occur. There's that notion with a symptom, isn't it? It's something you don't want and something that's wrong and that it shouldn't occur. The syndrome of feeling sad, low energy, weight loss, hopelessness, suicidal thoughts. Yep, that's sounding like things that tend to co-occur together, and when the more of them occur together, the more you should worry. Flags go up. Is there something wrong? Yeah, we have the ICD-10 and the DSM-5 now, where these sorts of symptoms have been found to co-occur together, and they do predict, a prognosis. So let's give it a name. So that's what we're doing. We're naming, we're categorising, and we're labelling, like we do with all those other phenomena in our everyday life. Sometimes we forget, though. It's not like, the apple. It readily predicts lots of things. It gives us a handle on something. This makes us feel like we've got a handle on it. But we don't have the level of the type 1 diabetes diagnosis equivalent in pretty much all of the mental health diagnoses. So that's where we're up to. So that's important to understand that that's what a psychiatric diagnosis means. And in psychiatry, we're trained to make a diagnosis, but it's also very important, and I think actually so much more important to do a good formulation. And so a diagnosis basically sort of answers the question, in what ways are two people with the same condition similar, like with the same diagnosis? How are they the same? What features would they have in common? And it's an attempt to sort and classify. And a formulation looks at things that would make how are two people with the same diagnosis different? What makes this particular person unique? And it's an attempt to understand how this person's come to this point and why now as well. So does that kind of make sense? And let's have a think. Why do we bother making a diagnosis? It's to provide recognition of a problem, and But more importantly, well, we're clinicians. It should be more than naming and categorising, because there's lots of ways of naming and categorising that exist in our society. That what makes us unique is that the client wants us to help come up with stuff, with things to do, steps to help that would reduce the suffering from this problem. So we want to influence with scope and precision. And what I mean by scope influence, I'm influencing you right now. I'm changing something about the way that you think. I'm adding to it, taking away from it, changing, we're all influencing each other. And in each clinical encounter, the client is attempting to influence us in order to help make something better for them, and we're trying to influence them. When a diagnosis is helpful is when it can influence us in what we do with scope and precision. Scope is, here's this problem, and these are all the different ways that we can do, things that we can do to help make it better. And precision is, this problem looks a little bit similar to a lot of problems, but there's this one thing I can do that helps your problem more than it would help the other problem. I think I might have gotten the words a bit the wrong way, but the idea is it's precise. There's this particular treatment, and then there's this range of things we can do, and we can differentiate it from something that looks a bit like it. Now, does that happen with a mental health diagnosis? I'm not sure how much I have time. The DSM, which is the Diagnostic Statistical Manual, up to version 5, is one and the most prominent classification system we use in Australia and in the US and many parts of the world. It's had its 5th version. Now, it's gone through many, many different phases. It's basically a list, a classification of psychiatric diagnoses. The number of diagnoses in that group has increased year by year by year, and it's gone through many different revisions. The types of problems out there probably haven't actually changed. It's the way that we've decided to divide up categories, divide up groups of, try and categorise experiences. So it used to be kind of very psychodynamically based until DSM-3, which was very revolutionary and had a huge impact. And it led to a much more kind of a medical way of looking at mental health problems. And it had a very big influence and led to a marked increase in research and funding. I might just skip that a little bit. So in terms of the pros and cons that I could think of in making a diagnosis, well, like labelling and classifying examples that I gave you before, it certainly is very helpful many, many times to classify information. It can help with research to group similar conditions and measure groups that are like each other to sort of see what works better. It can help with communication, and so that we're using the same language. It can help with recognition of the person's difficulties and to validate the person's experiences. It's like, I'm not silly, I'm not weak, I'm not alone, I'm not aberrant. There are other people with this type of problem, and it is a recognised thing. We've all seen how it can be very helpful. It can be helpful for advocacy and for funding, for example, in the school setting for some types of diagnoses. It can help inform policy making. I think the biggest one is it helps make clinicians feel better. It gives us this impression that we've got a handle on things, that we can capture something and sort of make it more tangible. Some of the downsides of making a diagnosis It can be pejorative and stigmatising, especially in, in the refugee and asylum seeker setting, where there's many, many different views of what it is like to, to struggle with mental health issues. It can be very reductionistic and simplistic. I'll talk about that a little bit more later, but there's this problem and there's what you do about that, which actually, as I've tried to explain to you before in terms of the medical model, hasn't actually yielded a lot of results. It can imply the problem is within the person. You have this thing. You have this thing and here's what it's called. It's a bit like you have an arm or a leg. You have this label. And it can lead to powerlessness or passiveness. It's like, well, what are you going to do to fix it? It's very, it can lead to a lot of passive sort of just presenting and getting fixed. It can pathologise normality. There's been, there's lots of discussions about this, but it has the potential, that sort of diagnosis creep where if 10 symptoms makes a diagnosis, if you've got 3, you're still abnormal, you're just a little bit abnormal. And it can dictate research agenda. Certain diagnoses tend to kind of attract more research funding. All right, so I didn't think it was possible to just talk about how culture affects, diagnosing in this cultural context without actually talking about diagnosis in and of itself. So I'll talk a little bit about then culture. Culture is a group shared set of beliefs, norms and values. I've just taken a very simple definition. As I said before, culture is all around us. It's not just when we're talking to someone from a faraway location or who has been experienced torture and trauma. The culture of the patient, and it refers to the culture of the patient, the culture of their larger society, the culture of the clinician, the culture of the organisation, the culture of this time in history as well. And it affects every stage of the clinical encounter, from assessment to diagnosis to treatment. So let's talk a little bit about the culture of the patient or the consumer. That affects whether they actually seek help in the first place. Do they actually see, what they see as worthy of, as a problem, as needing modification in some way? It affects the choices of the words they use, how they describe their symptoms, which ones they actually report, which ones they actually hold back from telling you about. Obviously, the quality of the interpreter and the translating service affects, it's part of that water that's affecting what we see. It affects the person's usual coping style. It affects the level of social support that may be available. And it affects how stigmatising a diagnosis of mental illness may be, or even just the idea that you're suffering from mental health problems. It affects the meaning of the illness and their way of making sense of the subjective experience of the illness and their distress. It affects what their explanatory model is likely going to be. And it affects the response of other people around them. Is it real or not? Is it in their body or their mind? Does it warrant sympathy? How much stigma there is with it? What might cause it? Sort of a person has this sort of problem. So there's some of the things that I thought of how the patient's culture might impact on their presentation. But we've got our own culture, and all of us have a slightly different culture. And then we share some similar cultures depending on whether we work at the Mater or in the private sector or with Metro South Health or with QPAS. And certainly the Western medicine tradition is prominent for many of us. this medical model, even the idea of psychotherapy is a culturally bound set of beliefs. If you feel bad, you need to talk about it. And the scientific method pervades a lot of what, how we deem what's an effective treatment. And we have a shared worldview about the interrelationship between the mind, the body, and the environment. We carry around assumptions. Rebecca and talked a bit about some of those things. This idea that healthcare workers don't have a hidden agenda and they're here to help you. Or if you're distressed, you shouldn't be and you need to not be distressed. Or if you don't feel right, go to someone and they will help you work it out. These are assumptions. When the client's sitting in front of us, they're kind of inherent, so we need to be aware of them. And the role of racism and discrimination is prevalent. We need to recognise it in ourselves when we're dealing with groups of people who we don't have a lot of experiences with, whose beliefs are vastly different from our own. That will play a part as well. And I'm just going to give you some observations of these are just my thoughts and experiences, and I'll be happy to, I don't know, we'll have time to discuss later on if you wanted to give feedback about yours, I'd love to hear them. But in terms of psychiatric diagnosis, unlike diagnosing diabetes, type 1 diabetes from other similar, conditions, the diagnosis in and of itself often don't predict what types of treatment might be most likely to help. That might surprise you, but it's actually not that hard to diagnose, say, major depression. If you look through the list, it's actually not that hard to kind of get someone to see that they meet all those criteria. But a lot of the times there's a lot of comorbidities. Yes, they have some features that probably would fit with a generalised anxiety disorder in our clients from refugee and asylum seeker backgrounds. If you specifically go asking for PTSD symptoms, most of our clients will have some of those symptoms. So I actually think there's a way that we've carved up the diagnoses, and that this approach we're using, they're basically phenotypes, they're clusters of things that go together, to see if we can predict something about that. It's just not a paradigm that's yielded a lot of results. So then, I was trying to think of an example. Have I got time with you? No. Can you humour me? Can I use an example? 2 minutes. So if you think about it, so let's try and see if you guys can make this diagnosis. Not a psychiatric diagnosis, just use your common sense, okay? Someone typically in their late 30s, early 40s, who might be seen around with a lot of high-vis lycra gear, who's got really expensive running shoes, maybe an expensive timekeeping device, or their iPod or iPhone strapped to their upper arm. They have really lean body mass, really tan body. They won't sit around and drink a beer and, eat lots of junk food. They're really, really health conscious. And they love swimming, cycling and running, Is there a diagnosis you can make of what that looks like? I'm thinking someone who probably likes doing triathlons, right? Someone who's probably doing triathlons. So what I've just done is given you a whole set of thoughts, feelings and behaviours that are observable, that tend to cluster together, right? And we kind of can recognise them when we see them on the street or at a, social gathering. Would we actually go, let's have a look to see if there's something anatomically or biologically different that causes people to be triathletes. That's kind of the approach we're using in psychiatry, and it's no wonder that we actually haven't come to a result that will give us something predictive. So when we're sort of saying someone's got major depression, what's the treatment going to look like? Well, we just need to be careful of language again. We just seem to have these medications that happen to be called antidepressants. Now, antibiotics kill the bug that causes your pneumonia or, you know, your encephalitis, or probably not encephalitis, but pneumonia. So without thinking, we can think that antidepressants somehow kill the depression. It zaps it, makes it go away. We're not actually treating any underlying cause, we're just treating symptoms. Antidepressants as a class of medications do turn down the level of, shall I say, how much you care about anything. And when you care so much about something, sometimes that can be helpful. Just like reducing your fever can be helpful with a pneumonia, but it actually doesn't cure the pneumonia. So often how I'm choosing medications is based on what side effects is it going to likely have, what's what's most acceptable to the patient, and what kind of things that they struggle with. So for example, if they're really lethargic and sleepy, I might choose an agent that's least likely to cause those side effects. So the diagnosis actually adds very little to the treatment. And then medication treatment is just a very, very small part. If we're looking at the formulation and in terms of the way we understand how depression develops, we do need to look at the past, the behaviours, the thoughts and the feelings that have led to this pattern. It's like a pattern that develops over time where the person's doing something that's helpful for them in the short term but actually sort of limits their life in the long term. That's how depression often develops. PTSD, I could go on and on about how that can develop, but if we're kind of just looking at it from a diagnosis model, it's actually very limiting. It can sometimes be helpful. For example, with PTSD, it is helpful for the person to say, it's not my fault, you know, it's probably a common reaction to trauma, but I think it's harmful if it's given sole importance. And diagnosis vary across clinicians over time. It changes so much. It's kind of certain things are trendy in some areas and not in others. So it tells you it's just about our concepts and how we organise the world. So as I've mentioned, and for reasons that we've discussed, we need even more caveats for using diagnoses in clients from different cultural and ethnic backgrounds, for all the reasons that we've discussed. So I think my time's up. Thank you.